We're going live now.
She'll go right ahead and call us to order.
Okay. Good morning, everybody. Thank you for being here. Today, we're going to be discussing suzetrigine for acute pain, the effectiveness and value. At the beginning of every Midwest CEPAC meeting, we want to be sure that all the speakers disclose any financial relationships with industry. So every member of our Midwest CEPAC panel who's present today has met the ICER conflict of interest policy. Would each Midwest CEPAC member please introduce themselves, their work, and note whether they have any updates to this declaration. We'll start with Eric.
Hi, everybody. My name is Eric Armbrecht from St. Louis University, and I have no conflicts of interest.
Alan?
Hi, I'm Alan Balch with the Patient Advocate Foundation, as well as the National Patient Advocate Foundation. I have no updates to my conflicts of interest. Thank you.
Bijan?
Hi, everyone. Good morning. I'm Bijan Bora. I'm a professor of health services research from Mayo Clinic College of Medicine, and I have no update to the conflict of interest that I already reported. Thank you.
Don?
Yeah, good morning, Don Casey. I'm Associate Professor of Internal Medicine at Rush Medical College, and no disclosures.
Gregory?
Good morning. My name is Greg Kerfman. I'm the Executive Editor of JAMA. I have no conflicts other than I am an editor of JAMA.
Sneha?
Hi, I'm Sneha. I am a patient and also executive director at Generation Patient, an organization representing young adults with chronic and rare conditions, and I have no updates to my conflicts of interest.
Ingiv?
Yeah, hi. My name is Ingrid Falketer. I am a professor here at Case Western Reserve University in Cleveland, Ohio. I'm also director of the Evidence Foundation and the U.S. Great Direct Network. I have no conflicts of interest to disclose.
Heather?
Good morning, Heather Guidon, Program Director, Center for Endometriosis Care. I have no updates or disclosures to address.
Jayani?
Hi, I'm Jayani Jawardena, an associate professor at University of Kentucky. I'm a health economist. I have no updates to my conflict of interest.
David?
Good morning. I'm David Kim, assistant professor of the University of Chicago. No conflict of interest.
Timothy?
Good morning. I'm Timothy McBride, and I'm a professor at the School of Public Health at Washington University, and I also co-direct a Center for Advancing Health Services Policy and Economics Research. They're health economists, and I have no updates to my conflicts of interest.
Jimmy?
Good morning, everyone. My name is Jimmy Olahere. I'm a patient advocate. There is an update to my conflict of interest. I participated in a clinical trial by the manufacturer that's here today.
Thank you. Stuart?
Good morning. I am a retired clinical cardiac electrophysiologist serving as a patient experience lead consultant for a Trinity Health large multi-specialty practice in southeastern Michigan, and I have no conflicts. Thank you.
Thank you. And last, my name is Jill Johnson. I'm the current chair of the Midwest CEPAC. I'm a clinical pharmacist out of the University of Arkansas for Medical Sciences. And so next, I think we'll go down the list of the patient and clinical experts. Please introduce yourselves and declare any potential conflicts of interest as well. Oh, I didn't say I don't have any updates to my conflict of interest either. So we'll start with Nicole.
Hello, everyone. My name is Nicole Hemingway. I serve as the CEO of the U.S. Pain Foundation. I am also a person that has lived with chronic pain since childhood, and I have no other updates to my conflicts of interest other than what's on the screen. Thank you for having me.
Okay. Gabe, I'm not sure if you're with us at the moment, but if you are.
Yes, I am here and no update to my conflicts.
Okay, thank you. Ben?
Hi, so I'm Benjamin Friedman. I'm an emergency physician and an acute pain researcher from the Bronx, New York. I have no updates to my conflict of interest.
Andrew? Not sure if Dr. Kolodny is with us. Can you hear me?
Yes, sorry, I was on mute.
Okay.
Yeah, hi, I'm an addiction psychiatrist with a background in public health, and I have no updates to my disclosure.
Okay, thank you, everyone. I would also request that any other speakers who are on the policy roundtable or any other participants who plan to speak, please announce any of your financial relationships with industry or other potential influences on judgment before you begin to speak. Thank you. Sarah?
Jill, thank you so much. I think my potential influence on judgment today is that I have suffered from acute pain, most recently when I broke my leg skiing, but I don't mean to make light, but I think we all have experiences that we'll be bringing to our own judgments of the evidence and discussions of value today. Before I jump into the introduction, Jimmy, can I just, for clarity, you've participated in a clinical trial from the manufacturer, but for a different disease area. I think that distinction is really important. Can you just confirm that for the listeners today?
Yes, I confirm that my participation in the clinical trial was for sickle cell disease.
Thank you, Jimmy. Just for transparency, appreciate that. So today, I am Sarah Iman, the president and CEO of ICER. We'll be hearing from some of our colleagues and collaborators today as we walk through the evidence. We'll be hearing from Dr. Brett McQueen, who is a health economist at the University of Colorado and led the modeling of for today's meeting. We'll be hearing from Dan Ohlendorf, our Chief Scientific Officer and Director of HTA Methods and Engagement, who served as our senior management team lead for this report. And then Dr. David Rind, who's our Chief Medical Officer, who served as the evidence author for this report. Before we dive into the evidence, I have this privilege of kind of setting the stage for why we're here today, why we hold these public meetings, and what we're hoping to accomplish. We always like to start by thinking about the patient. Ultimately, we want innovation that is delivering value for patients in the healthcare system because patients still need that. And again, not making light of the fact that probably most of us on this call today have suffered from varying amounts of acute pain, whether from a surgery, from trauma, or from some other disease process. But this quote really struck us. "I don't have an MD at the end of my name, but you are not in my body. You can't tell me what I'm feeling. The pain I have is real. I lost my identity and my career. I wasn't able to hike, run, or play with my kids like I wanted to. There's so much I wish I could have done." We're thankful to the patient and the patients and the patient advocacy groups who are with us today, who will help us remember that the patient is why we are all thinking about and talking about the evidence and value of this new therapy. Next slide. So why are we here today? Because when we have a new treatment approved by the FDA, there's often celebration. It can represent a new mechanism of action. It can represent an incredible treatment advance. Maybe it's even the first therapy for a condition. But after FDA approval, we still have a lot of questions, both as a healthcare system and as a society. What is the balance between the risk and the benefits? How do these new treatments fit into the treatment paradigm that exists? What are reasonable prices and costs to patients, the healthcare system, and to the government? And what lessons are learned to help inform future research needs so that we get the information that we want to answer these consequential questions about price and access to new therapies? Next slide. And we do this work because we also know that there are a lot of harms that are happening in our system because we are paying more and more for healthcare. And this isn't singling out pharmaceutical costs, but hospital costs are in there too. But when we have so many Americans facing challenges accessing their care, Americans going into debt, we want to remember their stories as we think about things today. We see the wards from Chicago who went $80,000 in debt because of the birth of their premature twins. We know the story of Sherry Foy, who was forced into bankruptcy because she had to have surgery to remove her colon. New research from the National Bureau of Economic Research showed us that a 1% increase in healthcare prices reduces labor income by 0.27%. So we can now track the direct impact that increasing healthcare costs are having on our wages. And that change flows into unemployment going up by 1%, lower federal income tax receipts by 0.4%. And we know that this often disproportionately impacts those who are lower and middle income. Next slide. So what we are charged with today, and part of the reason that ICER does this work and brings together this independent council, is that we can be focused on the patient in the room with the doctor, thinking about how to manage a new acute pain episode with this new therapy, while also remembering all of the other people in the healthcare system that need affordable access to care. We can do both of those things, and that will be one of the themes that runs through today as we think about the evidence and the value of this new therapy. Next slide. We are ICER, an independent nonprofit doing this research funded entirely by nonprofit foundations. We convene the Midwest CEPAC. They are independent of ICER. They represent expertise ranging from health economics to pharmacy to evidence-based medicine, clinical care, and patient and consumer perspectives. We are grateful for their service on our Midwest CEPAC, but they are here to keep us honest. They will be the ones taking the vote on their view of the evidence based on our review, their view of the value based on the price of this new medicine and other dimensions of value. And then we will be discussing the implications of those votes later on today. Next slide. I mentioned this funding. You can see a list of every organization that has given us money over the last 12 years. That transparency is very important. Excuse me, last 12 months. That transparency is very important to us and is available on our website. But as I mentioned, our research is entirely funded by nonprofit foundations. Any contributions that we get from manufacturers, health plans, PBMs, or provider groups supports a policy summit where we try to bring those groups together to tackle an important issue in the drug pricing space. Last year, it was how to pay for gene therapies. In just a couple of weeks, it'll be a new report on how to pay for GLP-1s for weight loss. So stay tuned for that. Next slide. This is almost at the end of about an 8-month process. We start by talking with patients and clinical experts in the manufacturer to scope the research questions that we think our expertise can answer from a comparative clinical effectiveness perspective. We develop that report, looking at the evidence, looking and building an economic model. We are thankful for the expert review that comes both from the clinical and the patient community to make sure that our contextualization of the evidence is in light of what clinical practice and patient experience reflect. We put out a draft report for public comment. We respond to every public comment, and those responses are available on our website. That's part of our commitment to transparency. And that revision after that public comment period forms the evidence report that will be the main part of our discussion today. So if you're on our website and kind of want to follow along, you can go to the acute pain section under assessments to look at that evidence report. It will be the basis of the conversation today. Next slide. When we talk about value, it's always good to remember what we mean. And so we'll be talking about what we have seen in the evidence for an improvement in quality of life for patients. When we look at life-limiting conditions, we're of course looking at if there's any extension to life with a new therapy. We do not shy away from conversations about cost, what new costs are introduced in the system with a new therapy, but what costs might be saved downstream. And this is always over a lifetime of a cohort of patients, and what benefits and costs do they experience. We also emphasize that there are things that are important into considerations of value that are difficult to quantify at times. We think about those things in the blue boxes. Benefits beyond health, special ethical priorities. We as a society value making treatments available to pediatric conditions. That's so an okay thing to say out loud. We know that when there's an opportunity to address a health disparity for a patient population historically disadvantaged by the healthcare system, that might be an important dimension of value that policymakers ultimately want to consider when thinking about the price and the access and the affordability of a new therapy. So these are the dimensions that you will hear us touch on today during our deliberation. Next slide. All right, you've almost made it completely through the opening remarks, and we're going to get into the meat of it in just a moment. We'll be headed to the presentation of the clinical evidence and the model. There's an opportunity for public comment and discussion before we break for lunch. After lunch, the CEPAC will deliberate on the key voting questions, which are also available on our website for those listening along at home. And then after a break, you're going to hear from me again. We'll convene a policy roundtable of experts, clinical, patient, payer, manufacturer, to know what are the ways to develop policies that are based solidly on the evidence that we have that are in service to affordable access to patients for this new therapy. After reflections from the Midwest CEPAC, we expect to be wrapping up around 4 o'clock Central Time. Really appreciate everyone being with us here today and for your attention for this introduction. At this time, it is my pleasure to introduce Dr. David Rind, who will talk us through the clinical evidence.
Thank you, Sarah. We're trying today to hand over control of the slides. So I'm about to request slide control, and we'll see how that all works for us. Looks like I've got it. I want to acknowledge the rest of the team, Dimitri and Finn and Sal. All of us work together on the evidence portions, comparative evidence portions of the report, and all of us have no conflicts of interest to disclose. So acute pain, as Sarah has already said, is ubiquitous. Everybody has experienced acute pain. Definitions vary, but clearly acute in the medical meaning is that it's time limited. We can be talking about 7 days, 14 days, but we're not talking more than 3 months. We're certainly not talking 6 months of pain. Somewhere between 6 weeks and 3 months, many people would talk about subacute pain. At least 80 million people in the US annually receive a prescription medication for acute pain. Nearly all the systemic treatments that are used for pain, for acute pain, are NSAIDs, acetaminophen, or opioid preparations. That's what's typically used. Today, we are talking about acute pain. Chronic pain is likely a much larger issue in many people's minds because it is such a big problem for patients, for families, for society. But the focus today, because of the evidence for suzetrigine, is going to be on acute pain. And I'm saying that because it's so easy to slip into thinking about the chronic pain implications of any therapy as it comes along. When we talk to patients, most patients and patient groups focus is around chronic pain. What we heard, as with what we heard around sickle cell disease, were concerns around undertreatment of pain, overuse of opioids for treating pain, and the stigma both of needing opioids for pain and of just being somebody coming in seeking help for pain. We heard that inadequate treatment of pain leads to patients going to the emergency department, which raises costs, and also patients hate going to the emergency department. We heard about lack of access to multimodal pain management, which is things like that typically pain specialists, anesthesiologists usually do, including regional blocks for pain and medications that aren't typically prescribed by non-pain specialists, that may alter pain sensation for a short period of time while a procedure is done, and that expertise in that isn't always available to all patients in all locations, and in fact is often quite limited. And of course, we heard about opioid use disorder and the opioid epidemic, which ICER has done many reviews that touch on. Opioids generally are being prescribed less frequently and in smaller amounts because of concerns around opioid use disorder. Their risks include sedation, confusion, falls, gastrointestinal side effects like nausea and constipation, and even respiratory depression when doses get high. The rate of opioid use disorder after short treatment of acute pain is uncertain. That's a clear uncertainty within our review. But most experts we spoke to think there is a non-zero risk, although again, the range varies a lot. And if you look at people who have prior opioid use disorder, the risk even after a short course of opioids is presumably and is shown to be much higher. When we look at NSAIDs for pain, these are readily available medications like naproxen and Motrin, ibuprofen, readily available over the counter for minor to moderate pain. There are also prescription forms. Their risks include GI bleeding, acute kidney injury, and even heart attacks, cardiovascular events. But the risk with a short course of treatment for acute pain is actually uncertain. That's not well known. And some pain experts feel that these medications are being underutilized, that people have become too worried about the harms of NSAIDs. And into this space comes the new medication suzetrigine. It's an oral medication for moderate to severe acute pain in adults. It's administered every 12 hours. It's an inhibitor of a voltage-gated sodium channel, 1.8. This is a new mechanism of action. We don't have any other drugs being used with this mechanism of action. It was approved by the FDA at the end of January. You can see in its brand name that I put there the NAV from the voltage-gated sodium channel. And one of the advantages we have of having representatives of the manufacturer here today is that they can answer one of the main questions we've had in the last month, which is how to pronounce the brand name. Additional insights from discussions with patients revolved around the need for education around appropriate use of opioid pain medicines. That different types of pain elicit different pain responses, that not all acute pain is the same. People gave the example that patients with migraine headache tend to want to lie down, close their eyes in a quiet, dark room, whereas people with cluster headache, another form of severe headache, tend to pace around and not lie down at all. We heard about openness to alternative treatments for acute pain that don't have the risk of addiction, that patients seek these things, and that patient-important outcomes include quality of life, physical function, and interference in activities of daily living, the development of chronic pain, the need for rescue medication, and avoidance of needing opioids, that these were all important patient outcomes. So as we look at suzetrigine, we need to ask, how does suzetrigine's efficacy compare to other options, and how does its safety compare to other options? Let's move to the clinical evidence. So mostly we're looking at 2 phase 3 trials. The study design was in 2 post-surgical settings, one after abdominoplasty, a soft tissue procedure, and one after bunionectomy, a bony procedure for bunions in the foot, in patients who are having a lot of pain on a pain scale. Patients were randomized to receive suzetrigine, an opioid preparation, hydrocodone combined with acetaminophen, or placebo. These were the 3 arms of the trial. People could get rescue medication with ibuprofen, and we'll be talking more about that. We don't have any peer-reviewed publications of these trials. Across the 2 trials, we have about 2,200 participants. 92% of the patients were female. And that's because that's mostly who gets abdominoplasties and bunionectomies. It's not that they were selecting for women. And the reason for abdominoplasty and bunionectomy is that that's the model, this sort of post-surgical model of soft tissue pain, post-op, and bony pain post-op is what the FDA is looking for approval of a new pain medication. About a third of the patients had severe pain and 2/3 had moderate pain at baseline. More patients in the abdominoplasty group had more severe pain. The primary outcome was an average of the pain intensity over 48 hours, but also looked at how long it took to get to a more than 2-point reduction in the typical numeric pain rating scale from baseline, and there were some other secondary outcomes. This is a graph of what happened to pain on the left after abdominoplasty and the right after bunionectomy. And as you look here, the black line is the placebo line. The gray line here is the opioid medication, and the blue line is the new medication, suzetrigine. And you can see that suzetrigine in abdominoplasty looked, like it was pretty similar to the opioid preparation. It may have outperformed it a little at the beginning, but that's really what you see here. And you see that the time course to relief is pretty similar with these two medications. If you move over to bunionectomy, it doesn't look quite the same in that at the beginning, suzetrigine doesn't look that different from placebo. And then it starts to separate further out that the opioid preparation gets pain relief quicker than suzetrigine, and then stays a little bit ahead of suzetrigine all the way through after bunionectomy. So what is it we don't know about efficacy? We don't have any head-to-head trials with the NSAIDs. The opioid dose used was low. It was 5 milligrams of hydrocodone combined with 325 milligrams of acetaminophen once every 6 hours. And that's lower than I think many people would use postoperatively, where often people would be given up to 2 of those pills of medication every 4 hours. We have issues around what we know about rescue medication use, and that's changed a bit since the FDA approval and now the publication on their website of some data that I'll share. And to look at what we don't know with NSAIDs and with higher dose opioids, we performed a network meta-analysis to do indirect comparisons with various trials. So in the network meta-analysis, we could find other trials of patients undergoing similar procedures for moderate to severe acute pain. And we could look at suzetrigine compared with NSAIDs and low and high dose opioids, all compared with placebo. And we were looking at this outcome of averaged pain over 48 hours. And this is a network meta-analysis set of results. And I know most people aren't used to looking at this, but if you want to know how high dose opioids did compared with placebo, you look at where the boxes meet and you see this 0.56, which is in standard deviation units. And this is sort of a moderate response. These bolded numbers are every one of these therapies doing statistically significantly better than placebo. Nothing else in here is statistically significant. And the differences are more in the small to very small range of effects. But if you had to look at a line of what's happening here, maybe high-dose opioids were a little better than suzetrigine, a little better than low-dose opioids, a little better than NSAIDs. Lots of uncertainty in this network meta-analysis. Rescue medications, what did this imply for us? So people could get 400 milligrams of ibuprofen if they were having ongoing pain. Initially, we didn't have rates of rescue medication. And I want to think about the implications of taking a rescue medication. Imagine a therapy not working very well, and so you take rescue medication very quickly. If the rescue medication is great, you might do better with that than a moderately effective therapy where you didn't bother to take the rescue medication. So that's the sort of thing that made us nervous about rescue medications. If you think about what that implies versus placebo, and I'm keeping this in even though we now have some actual knowledge of the effects, you might have predicted against placebo that it would make a new drug like suzetrigine maybe not look as good as it is because people in the placebo arm might take more rescue medication, and that would blunt the advantage of suzetrigine. Versus a medication like hydrocodone, you might expect that the opposite effect could happen. It could blunt how much better hydrocodone is if people are taking a lot of rescue medication with suzetrigine. All that said, we, in the last few days, now have graphs of this. You can see over on abdominoplasty that the suzetrigine group isn't taking very much rescue medication compared to the other arms. Everybody's taking a lot. This starts at 60% and goes up to 90% here. The placebo group in green, almost all of them are taking rescue medication. And rescue medication between suzetrigine and opioid medication looks very similar. But if you come over to bunionectomy, suzetrigine and placebo look identical. People are taking just as much rescue medication with each medication, much more than they're taking with the opioid. That's interesting. What don't we know around safety and harms? Pain medications need to be really safe. When we look at medications for diseases where you're likely to die, we worry less about small unknown harms. When we look at medications for pain, they need to be really safe. The information we have currently comes from clinical trials and from issues around biologic plausibility. There are always unknown risks with a new medication, and we have to think about the comparator risks of NSAIDs and opioids. In the phase 3 trial, suzetrigine was very well tolerated. Its side effects were similar to placebo. It had a lower incidence of nausea and vomiting compared with the opioid preparation, which is what you would expect. So what are the uncertainties? There was a study, a phase 2 study in chronic pain in patients with diabetes, where 6 of 55 patients who received suzetrigine for 12 weeks had a decrease in their renal function. That's at least concerning. They looked at a lot of possible harms, so maybe this was a statistical blip, but it's noticeable in this, and it's noticeable because it's one of the things we worry about with the NSAIDs. Brugada syndrome is a syndrome where people have a tendency to have fatal cardiac arrhythmias. The sodium channel that's being blocked here is encoded by a gene where mutations in that gene increase the risk in a proportion of people to develop Brugada syndrome. There are biologic reasons to think that blocking that channel shouldn't have the same effect as the mutation in the gene, but it's something that we noticed and is noticeable with a new therapy and that we thought needed to be watched for. And then we have the concerns about unknown harms, and I mentioned rofecoxib here, Vioxx, and the history of Vioxx, where it came on the market as a safer nonsteroidal pain medication, a COX-2 inhibitor, and then turned out to have higher rates of cardiac acute coronary syndrome than with naproxen, and got pulled from the market. We also heard that some clinical experts worry that with any new pain medication, there's still addiction risk. That said, this is a peripherally acting pain medication. We didn't see any reason to particularly worry about addiction risk, but we wanted to mention that we certainly heard this concern from experts. In terms of comparator harms, you'll be hearing in the economic discussion about the widely varying estimates of developing opioid use disorder after 1 week of treatment with an opioid. And that's very important in thinking about opioid harms. And NSAIDs, again, short-term risks. There's clearly some short-term risk of GI events, but maybe not so much serious GI events in outpatients. For cardiac risks, for renal risks, we just don't really know what the risk is over a few days. So in terms of overall uncertainties, we have uncertainties because suzetrigine was compared to a lowish dose of opioid. The time to benefit, you saw being different between what happened in bunionectomy and what happened in abdominoplasty. And even more with the rescue medication, you saw how in abdominoplasty, the rescue medication data weren't really worrisome at all, but in bunionectomy, patients were taking rescue medication as if they were getting placebo when they were getting suzetrigine. We don't have a head-to-head comparison with perhaps the most commonly used cheap medication for acute pain, which are NSAIDs. And then we have the known and unknown risks mentioned. In terms of benefits beyond health and special ethical priorities, many good patients are not good candidates for either opioids or NSAIDs for various reasons. Populations who are underserved by the healthcare system may be both undertreated for pain and overtreated with opioids, as I mentioned earlier. If opioid use disorder is reduced, there may be caregiver benefits, but that's a tiny fraction of the patients receiving the opioid treatments over a short period of time. And this has a new mechanism of action, which means, among other things, it could be synergistic and combined with other medications, and it could work for people for whom other medications for acute pain aren't working well. In terms of public comments we received, the manufacturer felt that our concern about the low dose wasn't appropriate because this dosing is the most commonly prescribed dose. But that's the most commonly prescribed dose because it's the most commonly prescribed dosage form. Typically, the dose post-op is for 1 to 2 of these medications every 4 to 6 hours. And in the study, it was 1 of these every 6 hours. We heard from a patient group expressing hope that suzetrigine would decrease progression to one of the chronic pain syndromes, chronic regional pain syndrome. Just want to remind everyone that we don't know the answer to this right now. We don't know whether suzetrigine decreases the risk of developing a chronic pain disorder. On our public comments, we got a lot of moving and interesting stories of the impact of acute pain and the impact of developing opioid use disorder, and I would encourage people to read those. So in summary, we think that suzetrigine has greater efficacy than placebo, maybe similar to low-dose opioids in terms of pain relief, but you see that difference happening with bunionectomy and abdominoplasty, where it really doesn't look as good for bunionectomy. We have uncertain comparisons with NSAIDs and high-dose opioids. On the harm side, we have the possible renal harms. I have to say I'm less worried about the cardiac harms. I remain always concerned about unknown harms with a new medication for a relatively low-risk condition. It's going to require time on the market to be sure about harms and large numbers of prescriptions. And presumably, the right way to sequence this is to give it first to the patients who are at greatest risk for harms from the existing medications. I set myself a timer to tell me that I'm done, but I'm going to just go through the evidence ratings. Compared to no systemic therapy, opioid analgesics, and nonsteroidal anti-inflammatory drugs, every one of these we rated as promising but inconclusive, meaning that there may be substantial benefit, but we think there's a slight chance of relative harm, generally caused by our concerns about unknown harms, but also some questions about efficacy compared with both opioids and NSAIDs. And with that, I'll stop. Thank you.
So we have several minutes here for anyone to ask questions on the panel. What questions do you have for David? Yeah.
Yeah, hi, David. Thank you so much for that presentation. And my question is a little bit more surrounding the trial data. So I was wondering, and I recognize we have limited access to that at this moment, but I was wondering, how does the analysis account for potential age-related differences in drug efficacy and safety for the adult subgroup? And specifically, do we know the strength of the evidence for young adults subgroup, for example, 18 to 26, 27 to 35, and more narrower age subgroups?
Yeah, so in the FDA data that was recently published on their website from the approval, we have big chunks like 18 to 45 and 45 and older, where it didn't look very different. But the populations you're most interested in, Sneha, we don't have tight groups the way you might want. And another group that we would have been interested in, I realize this isn't your focus exactly, but you would think a lot about elderly patients who are at high risk from opioids and from NSAIDs potentially. And there was an analysis looking at people who were over 65, but it was a tiny number of patients relatively. And so it's very hard for us to make any good comments based on age range. Possibly when the manufacturer talks later, they might be able to talk more to this.
Thank you. Gregory.
Thank you very much, David. A very nice, clear presentation. I wanted to ask, with a symptom as subjective as pain, whether you could say anything about the minimum clinically important difference I don't think you mentioned that in your very nice presentation, so I just wanted to bring that up.
Yeah, I think people feel at least on the time to pain relief, that 2-point that's used in there in an analysis that was done as a secondary analysis, that's supposed to be a minimally clinically important difference. And one of the reasons I didn't focus on that so much is we have some mean data, we have some median data. You might want a responder, non-responder analysis if you were looking at time to a minimally clinically important difference response, and mostly we're looking at averages here. And so on the average effect, I don't have a good way of answering that for you. I think you can see, based on how many people wanted rescue medication, that even if it met a clinically important difference, the vast majority of people wanted more pain relief after their surgery than they were getting from any of the 3 arms in this trial. And so that's noticeable.
Don.
Sure. David, thanks for the great presentation as always. I'm still struggling with this challenge of the trials and the procedures that were chosen for these trials, because we're, in thinking about, Jill, I should have disclosed, I actually do have bilateral bunions, but they don't need surgery. So, but in any event, I'm thinking just generally about the differences, David, in just broad terms of populations such as the study patients, certain elective surgical procedures versus, let's say, accidents. I fall down and I get a rib fracture, right? Or more complex patients, let's say a myeloma patient who unfortunately develops a vertebral fracture suddenly and is in horrible pain. And so I'm struggling with that. And the other part of that, with going back specifically to the procedures, is, bunionectomies are very different than abdominoplasties, right? For example, people with bunionectomies may be wearing special shoes afterward that help them walk, or be told to keep their feet up. And that relates to both the potential, at least in some of these procedures like bunionectomy, of using concomitant, let's say, regional anesthesia techniques that help mitigate postoperative pain, as well as, the many different non-pharmacologic modalities. And the second quick question is, we aren't really discussing the risks of harm for acetaminophen, but there are certain dose-related risks that, could be consequential. So I just throw that into the mix. But I wonder, about your reaction. I know we talked about this with Dr. Kolodny and Dr. Friedman earlier this week, but what's your reaction?
So, to be fair to the manufacturer, this is what FDA wants a new pain medication to study. There's no chance, given the many different types of pain that patients have, that we will have adequately powered randomized trials for every type of pain that somebody's going to choose to use suzetrigine for. And I really think we're all only going to really understand where it works better and worse after it's on the market and being used for a while. I just don't see it happening any other way. If you ask me to make a guess about whether it would be better for a strained muscle, given the soft tissue response, than for the broken rib, I would wonder about that. I think that's a fair question given what came out of this, but we'll know more after we've been using it. And it's not disastrous if we prescribe it for a broken rib and discover we have to give someone some other pain medication. So it's not as if we're talking about a treatment for a condition where if we pick the wrong therapy up front, we've made a horrible error. And if you ask, well, is this going to work well for headache? I have no idea from these. I don't know whether abdominoplasty or bunionectomy predicts well headache relief, but we will find out. And so I guess that's how I'm thinking about this right now as looking at this. I hope that's helpful in answering it.
Yeah.
Thank you. Inge?
Yeah, hey, thanks, David. It was great. Just a quick question from a methodological perspective, since you don't have access to full peer-reviewed reports, and when you did some risk of bias assessment, Obviously, it was blinded, so I'm hoping it was all done right. But you know, if I take oxycodone, I probably know that I'm taking it. Whether you had some thoughts on any residual biases in which direction they would point.
I was less worried, honestly, about loss of blinding, for instance, in post-op patients who are miserable and just want to be out of their pain and may or may not be noticing why they're getting groggy if they're getting opioids or something, than the implications of rescue medication, which you're choosing to get and isn't a randomized effect, of course. And so to the extent that I was looking at this, particularly before we had the FDA data, that was the big thing that was leaving me uncertain about efficacy. It still leaves me with some uncertainties. I'm more worried about it as in the grade indirectness category to how this compares to higher dose opioids and to NSAIDs than worrying that they got the answer wrong versus the dose of opioid being used. I think we can more or less trust the trial results against the dose of opioid being used.
Thanks so much.
Timothy.
Yeah, thanks. And again, I agree, great presentation. And I will self-disclose that I'm a migraine. I have migraines and have had them for 50 years. So I feel like I have a lot of experience with dealing with pain. It's gotten better over the years. But and I think your answer to Don helped a lot. Because I sort of am struggling. I get also with the choice of the conditions that were used in this trials. And if there's anything I gather from your answer that we can't really say much about headaches directly from these answers. You shook your head no. So
I don't think we know much about headache at this point.
Yeah, okay. And as a migrainer, as we like to call ourselves, do you know anything about rebound effect from these?
So that's a great question. We did not look to try to answer that at all within this study. And I could imagine when you get a peer-reviewed publication of this, somebody saying, gee, did you guys look at rebound at all? We don't, if there are data on that, I don't think we know it. Just for people, for the larger group, if you take acetaminophen for headache for a bunch of days in a row and then you stop the acetaminophen, there's a pretty high chance that you're going to get a worse headache after you stop taking the acetaminophen. There's a lesser issue of that with NSAIDs, but it absolutely also happens with NSAIDs. And opioids have a withdrawal syndrome, which blurs all this and makes it harder to figure out. But there's a whole set of conditions around pain reliever overuse, rebound, headache. And I don't think we know the answer to that with suzetrigine. If you imagine that the rebound is a central thing and these are peripheral, you'd go, oh, well, it shouldn't be such a big deal. But are headaches really a central thing? I mean, why does Botox work for them if they're a central thing? And so I don't know. But this will be another one of those questions that I bet we figure out over time. That one I bet takes a while.
Rebound's been a central thing for me for many decades. So, thanks.
David.
David, thank you for wonderful presentations. And I like to get into how the ICERs actually reach this evidence rating. So you put promising but inconclusive for all three different interventions, including compared to placebo, where the network meta-analysis actually show pretty, to me, like convincing statistically significant pain reduction. So first question is that how you ended up promising and inconclusive for the placebo. Second thing is that how much of this kind of divergent result between these two trials affects the ICER's conclusions in the promising and inconclusive. So you're just thinking about like more like taking average and then yes, we know because two different trials give completely different direction. That's how you ended up inconclusive, or kind of a little bit get to like a little bit more thought process about the decision making you guys did.
Sure. So we're always looking at net benefit, which is efficacy, benefits versus harms. And versus placebo, the questions from my mind are essentially all on the harms side. Not taking anything has no harms. If this has unknown harms behind it, if the renal signal turns out to be worrisome, if a new medication for like rofecoxib turns out to cause heart attacks, the benefit isn't going to be, even though this works, we're not going to be using this medicine if it's causing heart attacks. That's the placebo inconclusive. What leads to the inconclusive part. Against opioids, it's the lowest dose of the opioids and the divergent results in the two trials. And the NSAIDs, it's the lack of head-to-head. Because we know that opioids have some harms. We know NSAIDs have some harms. We may not know the relative harms, but more of the uncertainty is caused by uncertainties around the efficacy against the two active therapies. I would agree. I don't have any large efficacy questions against placebo.
Hey, David and Jill, I wonder if Dr. Friedman and Dr. Kolodny have any reflections on, especially those last two questions. They seemed that seemed the generalizability one and our evidence rating.
Yeah, I was going to agree with the sentiment that that unfortunately we're not going to know in the short term, and we'll have a much better sense of both efficacy and harms over a much longer term period. I mean, the data simply isn't there to give the answers that we're all looking for. For me, the most important comparison is one that wasn't done, which is it's unlikely that this medication is going to be used as monotherapy. It's most likely going to be combined with something else. So somebody will be started on an NSAID, for example, and this will be added to it. And so that that to me is really the clinical realm in which we're going to see it used. And so I welcome more data over the coming years.
Yeah, I would agree with the conclusions about promising but inconclusive. And I don't really think that with the very limited data that's available that it can be used to inform clinical decision-making in a meaningful way. So, I think there's still a lot we don't know. So the comparison I really would have liked to have seen would have been suzetrigine versus NSAIDs. I suspect, based on the little bit of data that we've seen, that the NSAIDs might have really appeared significantly more effective, but we don't know. And I think the indirect comparison that ICER attempted, I don't really think you can draw much from that, since it was indirect. I think you really needed to see a head-to-head trial there.
Are there any other questions or comments from anyone? Jimmy?
I know we probably don't have enough data to answer this question, but I wanted to ask David, just in his medical experience, if he knows the mechanism of action would cause patients to build up tolerance to suzetrigine. And I know we don't have any long-term data, but since it's a blocker, since the mechanism is quite different, I don't know if the science can give you that answer.
Yeah, I think it's a great question. Theoretically, this is working kind of the way local anesthetics work. You could imagine it as being a more selective lidocaine. And so it's blocking peripheral, if that's at least the belief as to how this is working, that's why it was chosen as a drug to study. And we don't usually think about local anesthetics as developing tolerance, but then we're not usually giving them over long periods of time at lowish doses systemically. The manufacturer is absolutely doing studies in chronic pain. They're very interested in chronic pain. And I think that's where we're going to get the answer as to whether tolerance develops. And I think we're going to know those answers soon, So rather than, unlike some of the questions that we've asked that I don't think we're going to know until this has been on the market for a long time, I think we'll know about questions like tolerance over the next year.
Eric?
David, can you explain again explain your reflections or conclusions regarding the rescue medications and to the degree to which it's an indication that the primary pain treatment is ineffective or insufficient? I'm trying to understand, like, is it a marker of insufficiency, like it's not working well enough and so it's added, and therefore I should discount how effective it appears even on the sort of the comparison curves? Just walk me through that again. I just
No. So it's completely fair. First, let's say that abdominoplasty and bunionectomy are chosen because they hurt a lot.
Yeah.
Right. I mean, my wife too has bunions and keeps going, but I don't want a bunionectomy because I don't want to be in intense pain.
Right.
So, these are really painful things. It's not surprising that people wanted more pain relief than they were getting, but they clearly wanted more pain relief than they were getting in each arm of the trial. So at that level, for that level of pain, almost everybody, 80+% of people, wanted more pain relief than they were getting from whatever arm of the trial they were in. However you want to think about that. That doesn't mean that it wouldn't have been adequate pain relief after a much less painful surgery or a less painful bone procedure, who knows? Separate from that, and the new information that we've had in the last few days, it's striking that the placebo arm and the suzetrigine arm in the bunionectomy trial were asking for exactly the same rate of rescue medication. And we saw less separation of suzetrigine and placebo in bunionectomy. And I wouldn't use that to say, oh, it doesn't work, but I'd use that to go, gee, maybe this isn't as good for bone pain as it is for soft tissue pain. We're going to find that out. It's on the market. We'll learn more about this. We don't need to have a perfect answer to that right at this moment, but it's not like that was an outcome of this clinical trial. Nobody was like saying, we're going to judge the pain efficacy based on rescue medication versus placebo over time. But you can look at that and go, I really want to watch what happens with bony pain with suzetrigine versus soft tissue pain with suzetrigine. Maybe we'll learn stuff over time.
I appreciate your comments. I was trying to take what Ben had said of like, hey, this is likely to get used in a polypharmacy like anyway, right? And so is it really a rescue medication, or is it two medications being used together?
Sorry,
as part of
I just want to make sure I didn't confuse things. It's not, when we're talking about rescue medication, it wasn't using suzetrigine as rescue medication.
No, I know. Yeah,
oh,
no,
okay.
It's the NSAID as rescue medication on top of it. Yeah, I understand that. So, but in practice, I'm just imagining that they're going to be prescribed together as a combinatory treatment, right? And yes, one of them is used maybe more kind of on demand by the patient in terms of rescue than the one that has a fixed schedule. But it's okay. Like that, your comments are super helpful. I really appreciate it.
I completely agree that the two early use cases for suzetrigine are going to be combining it with NSAIDs in people who can take NSAIDs in the hope that added pain relief will avoid needing opioids, and in people who can't take NSAIDs and or opioids where you need a different pain medicine. And there are lots of people who can't take opioids because I can't take NSAIDs because they're allergic or for other reasons. And I suspect those will be early use cases.
Right. It independently provides, maybe not sufficient, it provides substantial relief, or at least as measured by the 2-point reduction on the scale. Okay, super, very helpful. Thanks.
David, I have one last quick question, and that is, as far as the population that were studied in each trial, do we know, without having the phase 3 published, were all of those patients known to be without opioid use disorder? I mean, I can't imagine because they were not in the suzetrigine versus the non-systemic therapies. They weren't like unethically randomizing them to hydrocodone. So, you know, they were, it was,
Without the published trial, it may be that on the FDA website, we know the answer to that question. I don't think they would have randomized people with opioid use disorder to get to be on an opioid arm. So without knowing the right answer to this, I'm virtually certain they weren't including people with known opioid use disorder.
that's what I assumed too, but thought I would ask.
But the manufacturer can tell me I'm wrong if I have that wrong later. And I think I'm at time, so.
Yeah. Don, I'll give you a real quick question, then we'll move on to Brett.
Yeah, David, it's just a placeholder relative to the practice guidelines that are out there, especially the CDC guidelines. And I think that, you know, while it might take a while for an evidence review on their part, certainly thinking about how some guidelines might grade such a recommendation for this use would be perhaps something to think about in the future.
Thanks.
Thank you. Okay, so next, we're going to have a presentation of the evidence and the economic model that Dr. Brett McQueen led the effort for. He's an associate professor at the University of Colorado. And so, Brett, take it away.
Thank you so much. Yeah, Brett McQueen, associate professor and presenting the economic model, joined, I can't seem to control it, Grace. I'm sorry. Yeah, thanks. So our team in Colorado include Mike and Antal, and then Wuzhang from ICER, and really just the whole ICER team. I think I'm on, I don't know, I want to say 8 or 9 years collaborating with ICER, and it's always a pleasure. So it's very nice to see all of you. Our team has no conflicts to disclose. Next slide, please. So our objective was to evaluate the lifetime cost effectiveness of suzetrigine compared to combination of hydrocodone and acetaminophen for the treatment of moderate to severe pain, acute pain. Just to note, I'll be referring to both hydrocodone, that combination is just hydrocodone, and then also opioid-based therapy moving forward. Next slide, please. So when defining unmet need using equal value of life year shortfalls, both absolute as well as proportional, really what's reflected here, and because acute pain by its definition is a really short-term time horizon of less than 3 months, there's not enough time for this to add up in terms of quality of life changes. And so all of what you're seeing here in terms of unmet need is the excess risk of opioid use disorder from that upfront acute episode of pain. So take that into account with the other example conditions, because I think that's really important. And you're going to see that flow throughout not only the inputs and the model, but also the results. Next slide, please. Next slide. Not quite sure. There's a little bit of a issue on moving the slides. Okay, thanks. So for our overview of the methods here, I'll get into the model structure on the next slide here, but we start with a decision tree to capture differences in acute pain in terms of quality of life, but we also use it to allocate patients to sort of this lifetime, the lifetime adverse effects of opioid use disorder. So you'll see that. I'll explain that a little bit more when we get to the model schematic. Our outcomes are cost per quality adjusted life year gained, equal value of life year gained, as well as life years gained. And then we have a clinical outcome of cost per opioid use disorder case averted. Just a quick note that we also not only have our healthcare sector perspective, but we have a scenario with modified societal perspective as well. Our model schematic, I'll have you start on the left-hand side. And you probably see that timestamp on the top of less than 3 months or greater than or equal to 3 months to lifetime. That's kind of consistent with the definitions of consensus sort of professional guidelines. But really how we're doing this in terms of price and benefit is a 7-day prescription course. So you have surgery, you go home, you either have suzetrigine or you have hydrocodone. We compare quality of life differences, so they're embedded in the results, although we also realize, like I said in the unmet need slide, the differences in quality of life really aren't going to show up over the course of the lifetime, but they are embedded in the results. Then we use the decision tree to allocate patients to the lifetime model on the right-hand side. So first you have Markov model 1, which is alive, no opioid use disorder. That's just the typical American in terms of healthcare spending, in terms of quality of life, and survival. Then in the case of M2, alive and opioid use disorder, that's characterized by excess costs to treat opioid use disorder, decrements in quality of life associated with opioid use disorder, and of course, early mortality compared to the average American. There is a chance for patients to move to the opioid abstinence state where they, again, have higher spending than the average American to stay on, for example, medication-assisted therapy, and they may also have lower quality of life, and they have this leftover excess mortality, at least based on the evidence we reviewed. So I'll get into the inputs in a little bit and how we populated this model. So our target population is reflective of the average American experiencing acute pain. This same data source was helpful in determining the incidence of OUD from that short course of hydrocodone prescription. We have a number of assumptions, so you can read all of our assumptions and the model schematic and diagram. All of that's available in the evidence report. A lot of what I want to reiterate today is that we did not include, and I said this in the model schematic, we didn't include treatment for subacute or chronic pain, which is sort of that 3 months to lifetime. So that's really important. I already believe I stated this. If I didn't, we had the proportion of patients allocated to OUD from the suzetrigine arm equaled 0%. So we assume no risk from suzetrigine. We realize moving forward there might be some switching. We do not have evidence on that, and we did not include that in the model. For assumption 3, based on the available evidence that we reviewed, there really was no further transition to OUD after 3 years. So again, we're talking about one upfront acute pain, short course treatment of hydrocodone, then realizing OUD over the course of that 3 years after that time point. That's the evidence that we were able to gather for this review. 4 and 5 are assumptions related to simplification of the model. So because the cost effectiveness of OUD really involves medication-assisted therapy, that really wasn't our objective. Our objective was to model the adverse effects of OUD from this excess risk related to that short-term acute pain duration. So some of those include like moving from the opioid state to the abstinence state without the chance of moving back. Also weighted average quality of life scores for those seeking OUD and those not seeking OUD treatment or medication-assisted therapy. So some of these assumptions allow us to simplify the model structure, easier for the reader reading the evidence report, and also much easier to calculate these outcomes in a way that makes sense. And then finally, I think I already stated, we are looking at the adverse effects from opioid use disorder over the course of a lifetime. All right, so some of the most important inputs, you're going to see this throughout the presentation in the sensitivity analyses. That 3-year incidence of OUD in the hydrocodone arm is the most important input. And I'll give you not only sensitivity analyses, but a scenario analysis that I think will help with your interpretation. So really what that's suggesting is within a 3-year time period, for those that got that initial prescription for 1 week for hydrocodone, there is a risk over 3 years of getting OUD, a medical diagnosis of opioid use disorder, of about 0.43% or approximately 430 per 100,000. Then patients have a chance to move to the abstinence state where they stay, and again is characterized by staying on medication-assisted therapy for the duration of their lives. I think a lot of us all know this about opioid use disorder. There's a significant excess mortality risk, which is also included in the model through a standardized mortality ratio. The abstinence estimate is really applied to that opioid use disorder mortality estimate. And what that is suggesting is that although it is lower than OUD, mortality in the abstinence state is still higher than the average American, which is based on US life tables and varies by age and sex. Okay, so the treatment cost for suzetrigine, which was recently released, is a 7-day prescription. There's a loading dose, and then every 12 hours, there's another dose for a total cost for that week of $232.50. Then compared to generic hydrocodone, for the same duration is about $10.64. So that's going to be embedded in the costs over the course of a lifetime. And so hopefully you're thinking about sort of the offsets from OUD against this upfront difference in treatment costs, because that's going to be a big part of this. All right, so the other costs included in the model are excess healthcare costs for people with OUD, which are quite significant, annual costs of medication-assisted therapy, which are also significant and continue for a lifetime for those in that abstinent state. And then we have future unrelated healthcare costs, so like background healthcare costs. That's included in all of those states. So the M1, for example, also M2, and then that excess cost of OUD in the OUD state as well as in the abstinent state for MAT. So think of it that way, that we're adding to those background costs. So in order for us to calculate quality adjusted life years and equal value of life years, we need some estimate of either EQ5D scores or other instruments that can help us get there. In the upfront decision tree, we included a mapping instrument against numeric pain rating scales. It kind of varies, but really what we did was map over those scores and only apply them for that week duration to demonstrate any changes and embed those in the results. The rest of the utility scores are really characterized by disutilities associated with opioid use disorder, as well as that abstinence health state. All right, so let's see how this all played out in the results. So you'll first see the suzetrigine versus hydrocodone in the rows, and then in the far left-hand column, that total cost includes the upfront treatment costs per week. So the $232.50 versus the $10.64. And then you'll notice that there's this slight cost saving for suzetrigine. It's slightly lower, and that really is attributable to that excess risk of opioid use disorder from acute pain in the hydrocodone arm. You'll also notice in the middle, quality adjusted life years and equal value of life years are equivalent in this case. That's really because we're dealing with a general population. There isn't, for example, a chronic condition that we're modeling over time where you would see some of those differences play out for different treatments to treat those conditions. So those are going to be equivalent, and I'll speak to them as equivalent in any follow-up sensitivity analyses. As you'll see, suzetrigine has those gains over hydrocodone, mainly, again, due to the attributable or excess risk of opioid use disorder from acute pain. On the very far right-hand side is that 0.43% estimate, the 429 per 100,000 OUD cases within 3 years of that first prescription of hydrocodone. In terms of incremental results, suzetrigine versus hydrocodone is less costly and more effective across cost per quality, cost per EVLY, life year gained, as well as that OUD case averted. So as you can imagine, and I've already spoken to this, the yearly transition to opioid use disorder is the biggest driver of the model results by far. You can see that when we use upper inputs that are more consistent with persistent OUD use rather than OUD itself, or I should say persistent opioid use rather than OUD diagnosis itself, the cost savings increase or move more negative. And then in the lower input, there's when the risk is very, very low, that cost difference of the upfront prescription is starting to play out in the model. We also see the same result when it comes to health outcomes for this, in this example, quality adjusted life years. We see the same thing. Suzetrigine versus hydrocodone has this wide difference in terms of quality adjusted life years based on changing that yearly transition to OUD. I have one more scenario analysis that I think is really going to help with your interpretation. This is an example, though, of us modifying one input in the model while holding everything else constant, just to see the impact on the results. We also varied that transition to OUD along with all of the other inputs that have variation around them in the model, just to see over the course of 1,000 iterations, what proportion of those would be cost effective at these different thresholds. So 50, 100, and 150,000 per quality. And again, equal value of life years gained, same result. They're equivalent in this case. So we see a pretty high likelihood, over 90%, to meet those different thresholds for suzetrigine versus hydrocodone when we're using that $230-$250 versus the $10.64. We ran a number of different scenario analyses. So in the case of modified societal perspective, we included components outside of the healthcare system. So for example, criminal justice system interactions and resources used. We found really the same results, very consistent with the base case. The third was the exclusion of unrelated healthcare costs and death costs, found the same as the base case. The one I want to point you to that I think is the most important is we took that incidence of OUD in 3 years, that 0.43%, we reduced it all the way down until suzetrigine would meet 100,000 per quality and EVLY thresholds. That 0.02% represents about 20 per 100,000 cases within 3 years, which is obviously quite different than the 429. So I'm really hoping this scenario kind of helps you with the interpretation around the value of suzetrigine as compared to hydrocodone. We also did a health benefit price benchmark analysis where we took that weekly price of $230-$250 and then increased it based on those thresholds of 100,000 per quality and then 150,000 per equal value of life year gained. It's really important to note that that base case uses the 0.43% along with that price for suzetrigine and for hydrocodone. So take that into account in your interpretation of this evidence. There we go. All right, so there are some important limitations to note. The cost effectiveness of suzetrigine, I think I've made the case to you, I hope, that for acute pain compared to hydrocodone greatly depends on that incidence from a short course of hydrocodone for that 1 week. The societal perspective, as I kind of noted earlier, we may underestimate the economic burden. The economic burden of opioid use disorder is just massive, I think, as a lot of you know, and it's just really important to keep that in mind, that we didn't necessarily include every single societal element there. All right, so we didn't receive a ton of comments. The biggest change from the draft report to this evidence report is the update of the wholesale acquisition cost for suzetrigine following the FDA approval. That led to some changes in text in the evidence report. And then we also acknowledged some of the societal cost limitations that I just spoke about. So to conclude, suzetrigine for treating moderate to severe acute pain is slightly cost saving due to averting opioid use disorder compared to hydrocodone using that wholesale acquisition cost of $230-$250 for a 1 week prescription to treat acute pain. Thank you for your attention. I'll take any questions.
I have a question real quick I've been struggling with since I first read this. And thank you for that really great presentation. And please speak to me like I'm in 8th grade here. So on slide 61, where you talk about the base case, I can understand why hydrocodone has a cost of $197,000 over a lifetime because you're looking at the cost of OUD and the treatment for that and all that. How did a week of suzetrigine at $232 end up being $197,000?
Yeah, it's a really good question. So we're including the background healthcare costs for everyone in the model. So imagine that M1 state, you had your typical spending for the average American is included in that. So this spending isn't actually reflective of upfront suzetrigine. It's just reflective of your average American's healthcare spending over the course of their lifetime. That's where that lifetime cost comes in. And then the cost saving part is really only attributable due due to the OUD. So that's the difference, the differential. Averaged over the course of the entire population, what would that difference be if 0.43% got OUD within 3 years from that short-term 7-day prescription of suzetrigine? That's why I included in the scenario, even though it shows, and I think this is the complicated part, the scenario where we excluded the healthcare costs, the background healthcare costs, the costs are much lower than that because we're not including the background. It's just that the conclusions are hard to interpret when there's a cost saving scenario. So that's why we put them as just less costly and more effective.
Okay, thank you. David.
Thank you, Brett, for the excellent presentations. And I have, two high-level comments. So one more related to the evaluation itself, that ICER evidence rating made to suzetrigine versus the placebo, and then opioid, and then the NSAID, and then a value assessment only made to the opioid. So I'd like to just hear why you explicitly focusing on the suzetrigine versus the opioid. And then second thing is more related to the assumptions that you're using for 3-year incidence of opioid use disorder.
Yeah.
So I'm still a little bit concerned, right? To me, like you put most optimistic scenario for suzetrigine because you assume that there is absolutely no people who develop opioid use disorder because we don't know about their transitions into like other opioid medications later. But still, to me, like that's like extremely optimistic scenario. And then you use like the 0.4% the incidence of OUD for those who receive the opioid. But from the earlier discussions, in the trial is actually low dose opioid, not just the regular or the more like a higher doses of opioid. So when I look at where that 0.4% evidence comes from, it seems from the ICER poster presented in 2014. That particular study estimated the prevalence of 3-year OUD among those who receive all type of pain medications, including NSAID, anticonvulsants, local anesthesia, and then other kind of opioid as well. So again, the estimates was not really matching exactly, right? So you're using those all pain medications and how many of them develop the opioid disorder to those who receive like the low dose opioid for the comparator arm. And then for the treatment arms, you assume like, none of them actually develop opioids. So I think those are two very strong assumptions. So can you justify a little bit more?
Yeah, so I'll start with the second because I actually think Dr. Wren would be better to answer the first one on the comparison to NSAIDs. I think you're absolutely right to be skeptical of the evidence in this area. We didn't really find one source of evidence that directly answered that question, right? I think that was really the challenge that we ran into. And the evidence, which you reviewed in detail and you already know, is based on a claims analysis. So we don't really know the reasons, right, behind it. So you're absolutely skeptical. And that's why I showed the scenario analysis of what would the risk have to be. But yeah, I mean, I think you should, of course, consider the evidence base. I would say I don't necessarily think we, chose a particular assumption to be optimistic or not to be optimistic. I think the input is just so sensitive to the changes. And that was really the main point I was trying to get across in the presentation is what do you believe to be that estimate of after the short course? What is it? It's probably not 0. It's probably not 5 to 7% like some of the upper estimates are suggesting. So where is the truth? I mean, that's what we were trying to guide you towards is there is no clear answer. Although there are fairly decent evidence sources from claims data that gets us to a very small percent of people that end up with OUD. So you're absolutely right to be skeptical. I don't know, David, did you want to chime in?
Just on the comparison point, the manufacturer and I think everyone is imagining this as an additional potential alternative drug to opioids. If NSAIDs are tolerated and work, your naproxen for a week is even less than the $10 for the opioids, and there's no risk of long-term opioid use disorder. I don't think anybody is thinking, gee, why don't I use a $230 drug instead of $4 drug if it works? So we were trying to answer the question that's there. Now, do I really believe nobody's going to be prescribed this $230 drug instead of the $4 drug? No, this is the US. Lots of people will be prescribed it. But as we think about how you ought to be looking at it, I think the right way to look at it is this worth it if it was being used in this intentional way to avoid opioid use disorder? And our best guess is at this price, yeah, it probably is.
Thank you for that. Bijan.
Yeah, thank you. Brett, it was really good. My question is again, like, somewhat sort of, the overall goal, our philosophy of modeling. So we are really talking about an episodic, 1 week or less episode, right? These are kind of short episode, and now everything hinges on the fact that that 0.43 is essentially what's the probability of somebody having kind of hooked to opioid from this 1 week or less sort of episode. So that's sort of, I think that's you kind of answered. Yes, we are. I mean, maybe it is legit to be a little bit negative on that. But my other question was also about the fact that we are talking about these patients might also be using ibuprofen as sort of rescue medication. Did you not think about including that as well? Because I know that it's hard, and we would probably not know as to how much they would be taking. But if you really wanted to replicate what happens in real world, did you not think about including that as one of the ways that these patients might be receiving care?
No, I mean, we absolutely did think about it. I think it goes back to Dr. In's point that, well, first of all, the indirect results are always less preferred than the direct result. So this wasn't compared in the trial. So I think that was a little bit, even though to Dr. In's point, there's sort of a mix of use, we can in the future potentially, and I think a lot of people, there's a couple of maybe the clinical experts could chime in, this is probably going to be part of a market basket of options. And therefore, like the modeling that we did is one very specific scenario, and not necessarily one where people may mix and use like suzetrigine and then potentially hydrocodone. That's a possibility, right? So I think you should take that into account in your interpretation. And it's not that we didn't think about it, we just didn't feel the evidence was strong enough to include it.
Thank you.
Don?
Yeah, Brett, it's always good to see you at ICER, and thank you for so much once again. I always enjoy your evaluations. I asked David about guidelines, and it was sort of to tee up a question for you, and then maybe a brief point about shared decision making, which we haven't talked about yet. But first of all, it seems to me as though the opportunity here, forget about who's going to win the prize, is to highlight what I'll call, for lack of a better word, appropriate use in the context of rather specific decisions that are in the CDC guidelines, including strategies that have evidence behind them, such as giving limited prescriptions. And I know that it's rather blunt to make the long-range assumptions about opioid use disorders, but that's not to deny that you shouldn't. And just with due respect to Jimmy, that doesn't include, Jimmy, that's a specific label not intended for sickle cell disease. So I wanted to highlight that to you. You probably know that, but it makes me just wonder about, whether we should be thinking about appropriate use. And I think that the challenge is this doesn't have any strength of evidence behind it to work besides the guidelines if they're followed appropriately, and there are extensive recommendations there. And I think that leads me to this notion of what the most important part is, and I'm sure that our experts would agree. There's got to be a discussion about shared decision making, right? And so I'm not suggesting we know how to have that yet, but it seems as though it isn't going to be, here's a prescription, P.S. by the way, your insurance company might not cover it, right? So I'm just anticipating some of these real world opportunities. I'm not sure that it affects the projections in any way, but it seems as though, I don't know if you can work it in, but it seems as though these are sort of ideas that should be considered in the evaluation.
Well, the advantage of how we built the model, and if you noticed in the model structure, was that we can build in these scenarios later. So while we maybe have 100% in the suzetrigine arm moving to M1, so it's just the alive, no opioid use disorder, the interactive modeler that ICER has built allows you to adjust that in the future with that real world evidence. So I think that's a really important point moving forward. I can't necessarily speak to the shared decision making. I think that's probably maybe Dr. Kolodny, that's you raising your hand about that. But the model is absolutely flexible to include these scenarios in the future. I think the point of this is the initial prescription as rescue, given just what we know now. And that's really what we're modeling.
Dr. Kolodny?
Yes, thank you. I also appreciated your presentation, Brett. Your estimate for the incidence of opioid use disorder, just based on my understanding of the literature and my clinical experience as well, seem low. As you mentioned, and as we know, in the literature, there's a pretty wide range of estimates for OUD or persistent opioid use after acute pain use. But the numbers that you use, the Schoenfeld paper, I think is on the low end of that range. Other papers, for example, I'm thinking of the Shah paper that the CDC published, initial characteristics based on the characteristics of initial prescription, show much greater use. You also have to recognize that estimates of OUD after exposure to opioids that are based on claims data are going to generally underestimate how many people go on to have opioid use disorder. It's very hard to find OUD based on claims data. The other concerns I have is that you pick 5 days. The duration, though, of that initial prescription will dramatically influence the risk of persistent use. So again, in that Shah paper, with 5 days of persistent use, I think it was something with 5 days of continued use for acute pain, I think the estimate was something like 5% when we're still appeared to be stuck on an opioid a year later. When you increase that to 10 days, it went closer to 30% appear to be stuck on an opioid a year later. So duration would have been really important and would have really changed the findings. Age groupings also would have had an impact. So there is evidence that with exposure to opioids in adolescents, there's a much greater risk of the development of opioid use disorder or persistent opioid use. And even a claims data study, which, as I mentioned, would underestimate risk, found that after acute pain exposure dental work in adolescents, I think it was 6% appeared to have an OUD problem a year later compared to something like 0.1% of the adolescents that were not exposed to the opioid. So I think that's just something else to keep in mind. And then the last point I want to make that is a factor that I don't think was considered was when you put opioids into the community. I think, in the discussions here in the evaluation of suzetrigine versus hydrocodone, I think we're trying to take into account the risk to the patient. But when opioids are prescribed for acute pain, what we know is very often the prescription there are leftover pills, and those remain in the medicine chest. Those can easily be diverted, wind up in the community. We know that that's a problem. And when we talk about a drug like hydrocodone or oxycodone, we are talking about semi-synthetic opioids that have effects that are almost indistinguishable from heroin. So when you stock homes with a highly addictive drug, there's a risk there as well that I don't see that the analysis took into account.
So Thank you so much for that, Dr. Kalani. That's a really great perspective. And I want to reiterate that the 0.43% wasn't really chosen because it was high or low. It was chosen because that poster, while it is in the gray literature, was the best available evidence on answering this very specific question, which is, we acknowledge, extremely hard to answer, right? So we didn't go in with the mindset of we're picking a high or a low estimate. We went in with the mindset of this question that they're asking is directly related to the answer that we need to put into the model. So that's like point number one, okay? Point number two is in the interpretation of any sort of economic evidence, is the 232.50 compared to the 1064 worth it? Is it worth potentially removing the risk of opioid use disorder for patients by paying that extra amount? And that's not something I'm not trying to push you towards an answer. It's up to you to answer whether it's worth it, and you'll have to vote on that. That's really the question that we're trying to answer. And some of the downstream effects of OUD actually do include those, in the societal perspective, do include those criminal justice system costs. So that would capture some of those ripple effects through the system. But just to kind of maybe get back to a baseline of really what we're talking about here is there additional value for patients and society by essentially minimizing that risk almost to zero, if possible, by just using suzetrigine? That's kind of the question that we answer to all of your points. It's not going to be that way in the real world. There's going to be a mix of treatments. We totally get that. So.
Thank you, Brett. Those are all good points. Timothy.
Yeah, that discussion was a good lead into my question, and I'm staring at the tornado diagram on page 27, and I think you presented it. And partly it's my own eyes that have a problem reading this, and but I think that and Jill's question earlier about the interpretation of the numbers, and you just mentioned it's the cost savings of about $400 if I understand it. And so the tornado diagram looks dramatic when you look at it, but if I see it, if it ranges from like negative 7,500 to some positive number, which I can't figure out.
Plus 200.
Plus 200.
If you want to see that, supplement page E8 has the
E8. Well, that's in part what I was going to ask you, but in part related to Dr. Klodny's question. And, so I understand that's like a range, but, interpreting it is trying to figure out, you got a range, but what is the likelihood that you'll end up at one part of the tornado or the other? And you probably don't know that, or, and to his point, is it 0.43? Is it a higher number? But on the other hand, your other presentation was, we're pretty much in the cost-effective realm anyways. Is that how I should be thinking about it?
Yeah. Yes, I think and just so for those of you who are interested in that tornado diagram, there's a footnote that says the upper bound estimate for that cumulative incidence is 5.7% because it's in a yearly transition. That's kind of what Dr. Kolodny was referring to, some of those upper estimates, and then it goes all the way down to zero. So when you think of likelihood, I would actually point you more to the probabilistic sensitivity analysis. Even though we use the mean around that 0.43%, we're varying it so much in that analysis along with the other inputs that we're getting more of is this just cost effective at these thresholds? And it's over 90%, so there's still a pretty high likelihood, even when we include some of these upper estimates, that it is cost effective. It may not necessarily be cost saving in every one of those scenarios, but again, I just think of it as sort of the average being the 0.43, because I really think at some point you have to look at this from the most likely is the evidence that was generated. I totally agree with Dr. Kolodny that 0.43 is probably a lower bound estimate based on claims, but it was the best available evidence that we could find, and it's updatable. So, but you're right on your interpretation.
I think we have time for one more quick question, and then we'll move on to the public comments. So, Gregory, you got the last question.
All right, I just, there've been a number of comments along the lines of we're going to end up with combination pain therapy, that suzetrigine will be used in conjunction with other pain medications. I just want to point out that in these unpublished phase 3 trials, where we've had no peer review, that there is no data on combination therapy. So combination therapy would be something doctors could pursue, but there's no evidence about it whatsoever that suzetrigine would add any additional pain control to other agents.
That's a really good point.
It's a good point to be made. Thank you for making that point. At this point, I think we will go on to the public comments.